now. The meeting is being live streamed. Got it. Okay, right. Okay. So the elephant in the room, therapeutic hypothermia in India. So today I'll be focusing on mild HIE, which is an increasing problem in our population, and I'm sure in most parts of the world now. Okay, so let's start off with the story of a little girl who was born at 39 weeks gestation of a cord prolapse. So the little girl went for an emergency cesarean section, was very flat and pale, and required extensive adrenaline, resuscitation, cardiac massage, and had very low APGAR scores. Unsurprisingly, she was unresponsive and began having seizures at 3 hours of life. So the diagnosis, very obvious, is hypoxic ischemic encephalopathy, or HIE. So this stands for hypoxia, which is not enough oxygen, plus ischemia, not enough blood, leading to encephalopathy or brain injury. As you know, severe HIE accounts for 1/4 of all global neonatal deaths. That's almost 1 million babies every year. Half of these babies with severe HIE will die, and if they survive, 1 in 5 will have a major disability like cerebral palsy. Even without a major disability, more than 3/4 of them will have cognitive and other problems such as autism and behavioral issues that significantly impair their daily function. Now, severe HIE is common, as you all know. In high-resource countries, the rates are about 1 in 3 to 1,000 live full-term births. In low and medium resource countries, it's about 20 per 1,000 live term births. And the death rate is significantly higher. So this slide shows the pathophysiology of HIE, which you're all very familiar with. You have the insult, which starts in a few minutes, leading to primary energy failure, such as reduced ATP. We resuscitate the baby and we perfuse the hypoxic area, causing oxidative stress, toxic free radical production, and that leads on within 6 hours in laboratory animal studies to irreversible cellular injury, which results in HIE. So what can we do? So in the last 2 decades, we have found that using air instead of resuscitation, instead of oxygen for resuscitation at birth, will significantly decrease the risk of death from HIE. So Ola Salsted and Siddharth Ramji from Delhi led the first studies in using air to resuscitate babies at risk of death in HIE, and they found that this reduced the risk of death by more than 30%. However, using air alone does not make any difference to survivors that we know of. The follow-up studies are very sketchy. The REST-S studies only followed up 213, or about 3/4 of the babies at 2 years, with questionnaires and neurological assessments, and they found no difference in major disability. At that time, it was postulated that it was probably unrealistic for air to be routinely used in all infants suffering from depression at birth, and they didn't consider long-term outcomes. So what more can we do? Now, taking back the pathophysiology slide, we want to reduce the risk of irreversible cellular injury. And this is where hypothermia comes in. The role of therapeutic hypothermia is simple. What we do is we cool the body or the head to 33 to 34 degrees Celsius, not too cold. Maintain it for 72 hours, as shown in animal studies. This leads to slowing of the metabolic rate, and that allows the brain cells to recover. In adult studies, every 2 to 4 degrees reduction in the 2 to 4 degrees Celsius reduction in systemic or selective brain temperature will improve survival from adult stroke, trauma, and cardiac arrest. Cooling the body or the brain down will reduce cerebral energy metabolism, which leads to reduced free radical production, and reduction of glutamate release, which is an excitatory neurotransmitter that causes seizures. Cooling the body also increases good things like N-acetyl aspartate, which is a major source of myelin, brain fluid control, proteins, and it preserves antioxidants and cerebral ATP. We now know that therapeutic hypothermia, if introduced within 6 hours of life, will decrease the risk of death in moderate to severe HIE by about 30%. However, it's only beneficial in moderate and not in severe HIE. It also has questionable impact on neurodevelopmental outcome. We have to remember that the largest study, the TOBY study group, only followed up slightly more than half of their patients. They found that survival with an IQ above 85 was better with hypothermia, but to date, no study has sufficient power to show definitively that hypothermia improves cognitive outcomes. Regardless of hypothermia, more than a quarter of babies with moderate to severe HIE, if they survive, continue to have subnormal IQ. More than 30% will need education support, including 1 in 5 children with quote-unquote normal IQ. Therapeutic hypothermia is also very hard work. You can see this from our very crowded nursery a few years ago. You have the cooling blanket at the left side, the nitric oxide machine because the baby has pulmonary hypertension from meconium aspiration. You have the ventilator, the AEEG monitor, the nurse on the side, and finally the little baby at the end. So it's not easy to provide therapeutic hypothermia in a controlled way. It has many side effects, and sometimes that happens even with the best of care. So a meta-analysis of more than 1,300 infants found that cardiac arrhythmias, thrombocytopenia, bleeding, coagulopathy, metabolic dysfunction, and worsening of seizures was quite common in therapeutic hypothermia. We're all familiar with the pulmonary effects of hypothermia, including increased pulmonary hypertension, surfactant dysfunction, leading to stasis pneumonia. Some babies undergo fat necrosis, which looks really ugly because brown fat is more sensitive to hypoxia. This is usually self-limited, but may lead to devastating hypercalcemia, hyperlipidemia, and low platelets, and of course, bleeding. Rewarming itself is also quite difficult. The rectal temperature or core body temperature must be increased to normothermia by maximum of 0.5 degree Celsius per hour. Vital signs must be checked every 15 minutes and then hourly, and there's a lot of intense blood work during and after rewarming. Because rewarming may cause serious complications such as profound hypotension, hypoglycemia, bladder atony, coagulopathy, rhabdomyolysis, ventricular arrhythmias, and including seizures. So who do we cool? We know from animal studies that we have 6 hours to decide. This is the guideline for our therapeutic hypothermia practice in our state of New South Wales in Australia for moderate to severe HIE. And it focuses on the babies who are classified clinically to have SARNet stages 2 to 3. The other criteria are very familiar to you, so I won't go through them. So I'll do a little name dropping now. This is me before COVID lockdown with Dr. Sarnet in the middle and Dr. Sarnet on the left. And the SARNet score was developed in 1975 based on Dr. Sarnet's analysis of babies with HIE, about 26 of them over 1 week. So he did serial EEGs and clinical evaluations and found that the natural course of HIE worsened over 12 to 24 hours. Using the clinical presentations of these babies, he could divide them into 3 categories: mild, moderate, and severe. So moderate and severe, nowadays, we will not hesitate to provide extra treatments such as cooling. However, what happens to the mild babies? Okay, the difference between the SARNet score then and now is that In 1976 and 1975, Dr. Sarnat did not have neuroimaging. He did not have EEG or AEEG to guide his practice, and he did not have access or knowledge of the neuroprotective strategies that we currently use nowadays, such as cooling, magnesium sulfate, and other medications. The modified Sarnat score was based on a point system, assuming that normal is different from encephalopathy. So we move on to our next baby now, a little boy born at 39 weeks as well from a spontaneous labor. He had a poor fetal trace, so the mother proceeded on to a cesarean delivery, and he was given positive pressure ventilation at birth. So not too bad, and his APGAR scores weren't too bad either. So they brought him into the nursery because they did a routine cord pH, which was 6.9, and the lactate was 17. He was noted to be very alert, so they started feeding. He wasn't cooled because he didn't fit the criteria. And at 7 hours, he did so well, he was sent to the postnatal ward. So what happened? At 12 hours, he had a seizure, and he was beyond the window of cooling then. And when they did an MRI, he had occipital changes on day 5. So this is a mild baby that we are all increasingly faced with now that we have the option of therapeutic hypothermia. So in Dr. Sarnat's scores of the 21 HIE babies in 1976, what he did and what he found is serial CNS examinations and EEGs. As you can see, over 2 to 3 weeks, he found that babies who were in stage 1 or mild encephalopathy could progress onto stage 2. However, if their EEG was normal at 5 days, they had a good outcome. Some went on to stage 3 within hours, but sometimes up to 4 weeks. And of those ones, that was bad news. They died. But what we're learning is that mild HIE may not really be mild, because mild means that it's okay. So we only have 20 babies from cohort and randomized controlled trials of moderate to severe HIE babies that were inadvertently included. So these babies tell us that 25% of them had abnormal outcomes, and most of them were from cohort studies. The few babies that were included in randomized controlled trials have not shown a significant difference in outcome, whether they were cooled or not. We have no definition of mild HIE based on our criteria for cooling. We do not have the benefit of serial neurological examinations over the few 6 hours, and we have no idea what biochemical markers mean. Our cooling criteria in moderate to severe HIE really does not apply to mild HIE, and although we do other biochemical and neurological markers like lactates, CRPs, S100s, troponins, and creatine kinase, we do not know what they mean in mild HIE. If you like AEGs, we now know that there is no known relation to outcomes in mild HIE. If you don't cool the baby, the background amplitude will be predictive of outcomes. But if you do cool the baby, an early AEG has limited predictive value. What we do know is that if you have a baby that you're concerned has mild HIE, if it has a normal background pattern and very fast commencement of the sleep-wake cycling pattern, probably before 6 to 12 hours, the baby has a good outcome. The only cohort study so far that has looked at long-term, that is up to 2 years follow-up of babies with mild HIE, is the PRIME study led by Lena Chalek there from Texas. So this stands for, my slides are not moving. So this is this is the only cohort study, as I said, but it's only very small, 54 infants. And in this study, the AEEG was normal in 50. But despite this, when Lena followed them up, 16% were disabled, and more than half had at least one Bayley scale below, one standard deviation below the mean. And the children with abnormal MRIs and discharge examinations had an increased risk of disability. Neurodevelopment in mild HIE is quite concerning because we see abnormal neurodevelopment in up to 1 in 3 of babies diagnosed with mild HIE. Half of them at school age will have MRI abnormalities, and generally the IQ is lower and they have an increased incidence of attention and behavioral problems. So currently, we only have therapeutic hypothermia that has been shown to be moderately beneficial in babies with moderate to severe HIE. So is cooling beneficial in mild HIE? If you have cooled the mild HIE baby before who's unintubated, it's a very uncomfortable process. The baby's shivering, they look terrible, they're pale, and everyone's distressed. So, but what we know from animal studies led by Alistair Gunn's group in Auckland, we know that after mild injury, neuroprotection is even better with cooling than with moderate to severe HIE. But however, the cooling must be applied within the same therapeutic window, that is before 6 hours and continued for 72 hours as with babies with more severe disease. In mild HIE, half of the babies have abnormalities and up to 1 in 4 have severe abnormalities. And these are all the changes you can see. And this happens despite cooling, although the studies are very small. In a very small study led by Sudhin Thayil, cooling will improve neuronal markers of injury. Currently, we have very limited evidence that cooling for mild HIE babies affect long-term outcomes, which is a holy grail of treatment because babies with mild HIE are unlikely to die. Despite this, therapeutic creep is here. In a UK study led by Sudhin Thayil's group 4 years before, out of 48 NICUs surveyed, more than 3/4 would offer cooling to mild HIE babies, and they would cool out of criteria babies, such as those older than 6 hours of age. The UK and rapidly around the world is losing equipoise for cooling in mild HIE. And cooling was done in all sorts of ways. Some discontinued cooling before 72 hours, some would do an MRI, some would do a neurodevelopmental follow-up. There was no strategy. In our state of New South Wales, we have very detailed databases of all babies admitted to one of our 10 NICUs. So out of the 40,000 admissions between 13 years to our NICUs, 1,300 were diagnosed with HIE. 1 in 3 were classified as mild, and as you can see, they range from anything from 25 to 42 weeks, 750 grams and above, and had 5-minute APGAR scores ranging from 0 to 9. Cooling for babies in mild HIE increased from 45% to more than 3/4 of the babies just recently. The duration of cooling was wild. It ranged from 1 to 95 hours, 1 in 3 ceased before 72 hours, and 9 babies who were classified initially with mild HIE even died. So what can we do? Hang on. Okay, sorry. Oh, one last thing. Can cooling cause harm? What we have to be aware of is that if the brain is not hypoxic, cooling, as shown in animal studies, will increase the risk of neuronal injury, especially in the anterior putamen and the motor cortex. So to answer our questions, we rapidly need an RCT. We need to define mild HIE, maybe broaden our diagnosis by increasing acidosis criteria, and incorporate strategies that we use as a normal in today's practice that were not available for Dr. Sarnat in 1976. This will include evaluations of AEEGs, biochemical markers, examine the duration of cooling, and of course, increase the sample size to show relevant outcomes, especially neurodevelopmental injury. So there are currently several studies happening in the mild HIE cooling arena. So in the UK, Sudhin Thayil is leading the COMET study, which stands for Cooling in Mild Encephalopathy Trial. So in this study, he is not randomizing babies to cooling or not cooling, but to degree of cooling. So in group A, they're randomized to cooling plus normal care for 60 hours and 80 babies. In group B, to a shorter duration of cooling, and the primary outcome is an MR spectroscopy at 1 to 2 weeks. It is not powered for clinical outcomes. The TIME study, standing for Therapeutic Hypothermia for infants with mild encephalopathy, is the only study that's currently funded to look at short-term outcomes, clinical outcomes for babies with mild HIE randomized to cooling or not cooling. So this is run in the US, but as you can see here, the numbers are very small, only 68 infants. So we are planning the COMFY study. It stands for Cooling in Mild Encephalopathy and the Future Neurodevelopment of Infants. We want it to be a multi-site international study, and it's currently unfunded. It's very challenging to ask for funds for mild encephalopathy and cooling. And we have 52 hospitals from around the world that have expressed interest in joining. So if anyone on this call is interested, please message me. So the basic premise of this study is an RCT of cooling versus no cooling for the same standards as for cooling for more severe babies. And as you can see here, calculating the sample size to reduce the risk of death and neurodevelopmental disability at 2 years by about 20%, we need more than 520 infants. So it'll be a very challenging study. So part of our study would be to look at the neuroimaging of babies who are cooled and uncooled, and we would want this to be an unintubated infants under feed and wrap. So in conclusion, I would say that mild HIE is a major diagnostic and treatment conundrum that's taking over the world. 1 in 4 we know have long-term problems regardless of cooling, but our only mode of treatment available currently for HIE is cooling. Cooling itself is resource intensive, potentially unsafe, but also enticingly possibly beneficial in reducing neurological injury. Because the lack of equipoise is sweeping the world, and it'll be increasingly hard to find countries that do not consider not cooling mild HIE babies, we urgently need a large enough RCT with expanded entry criteria to include biological and physiological entry points to finally answer this question. Thank you, and I hope I haven't kept you back too late.
Thank you. And as of now, there has been 2 questions. One is that in case the blood gas, which is abnormal for the cord blood gas, but it normalizes by 1 hour. So the participants wants to know whether you will classify it under mild HIE or not.
Yes, that's a good question. You have to remember that Dr. Sarnet's classifications of perinatal depression was based on clinical criteria. So if the neurological status improves incredibly well, then usually the baby does not have HIE. But as you know, the mild HIE babies are very, very challenging. They can appear very well, and then suddenly they become sick, usually after 6 hours of age. But I would say that if your initial blood gas and your subsequent blood gas in a few hours' time are absolutely normal, you can probably adopt a wait and watch approach.
Or maybe they can do Thompson score or Sarnath scoring, whatever they are following.
Whatever you're comfortable with. Yes, exactly. As long, I would say that as long as you are comfortable with the score and familiar, I don't think it matters what you use, although the Sarnath has been shown to be more, I guess, precise than the Thompson. But it depends on how well informed you are of either score.
And another question which participants want to understand is that recently from LMIC, there was a trial which was published and it was by the name of Helix trial. Say they want to understand your opinion on the same.
Okay, that's a loaded question because the Helix trial created a lot of contention in low and middle income countries, especially in India, where it was run. So I think that's probably beyond the scope of this talk, because this talk is focusing on the mild HIE infant. What I can say is that therapeutic hypothermia is increasingly accepted as standard of care in many countries, including low and middle income countries. And I think what has been shown to be beneficial in a higher income country should be adopted or evaluated in a lower and middle income country, because these are the countries that are bearing the brunt of encephalopathy. So my opinion on this Helix trial could go on for like 3 hours, but I would probably not enter into that discussion in this meeting.
For the participants, because only message I would like to say, for your opinion on Helix, you can look into the NNF guidelines, one, and another is whatever were the challenges with the trial, whether inclusion or exclusion criteria or outcome, the scientific background and evidence, there must be a truth in whatever they are saying, but there's a way of presenting whatever you want to say. So the more repercussions are invited if your language of scientific writing is not correct. How you are commenting on the authors, you cannot be generalized. For generalizability, you have a definition. Everything in science carries a definition, so generalizability should also be weighed against a definition. So the another they want to know is that what investigation do you use in your unit during cooling of mild HIE babies, and how often they should be carried out? And
Okay,
third thing, with the same, are you going to feed these babies?
Okay, very good question, Bonnie, because there is no guideline for mild HIE babies in many parts of the world. So what we do in our unit will be very different to what you or what someone in the States or what someone in Canada, recording stopped, Thailand does. So if a baby is cooled in our unit, regardless of whether they have a severe, moderate, or mild disease, the first investigations we would do is, monitor the serial pHs, start the baby on AEEG monitoring. Oh, I'm getting distracted by Himesh Sharma asking for ultrasounds. All right, AEEGs. And we do all the standard moderate to severe encephalopathy cooling protocol. It's standard. Whether we intubate and sedate the babies is very clinician dependent. I know in France, it is standard of care to intubate, sedate, and ventilate babies with mild HIE who are undergoing cooling, even though they don't need it for their respiratory status. Do I feed the babies during the cooling period? Usually we give some trophic feeding, because otherwise the babies, if they're not sedated and ventilated, may be quite distressed. But if you feed too much, then you also, you're in fear or concerns of causing some ischemia to the gut as well, with an increased solute load, although that has not been proven. So we will usually give about like 5 mils every 3 hours just to keep the babies happy.
So now if they want to, sorry for interrupting.
No, I was going to go on to the next question.
Next question.
So I was proposing the
same one. So it was like role of ultrasound in first 24.
Yes, definitely. To look for gross abnormalities, although usually they're not very informative. And the standard of care would be an MRI after conclusion of cooling.
So for the one who are looking for ultrasound modalities, what I find is residents are predominantly looking at the sagittal and coronal views and are commenting only on the lateral ventricles. So your window has to be focusing on not only on that, but also you have to take a temporal view and you have to look at the cerebellum also. So these are the areas they may also bleed. So you are not ruling out the bleeding in these areas. So you may do, and maybe some of you want to know that in case the bleeding is there, or IVH at least is there, or DIC is there, so should I continue or discontinue? Maybe one of the apprehension while you are doing the ultrasound and you find that there is intracranial bleed. So would you continue, or you would stop cooling and begin with the rewarming?
Mhm.
So this is another question, and uh, related to imaging. So the next is not related to imaging, so we'll talk about that later on. So they want to understand what are they looking at MRS.
Okay, the best study to look at MRS spectroscopy in mild HIE is from Sudin Tiles group, who look at, I guess it was a very a smallish study. I'll just show you the slide again. Can I share my screen again? So what he did was he found that cooling, can you guys see that?
Yeah.
Oh my God, you guys see that? Okay. So cooling would reduce these markers of neuronal death, cell membrane integrity, and white matter injury. Although we have to be cognizant that MRS has not been shown to be predictive of either death or neurodevelopmental outcomes in babies with mild HIE because we don't have the numbers.
So the another is how to feed if parents choose not to cool. So you can go ahead with the simple your gavage feeding and keep on assessing the reflexes. That is the answer. I think from gavage, then moving on to your spoon or breastfeeding, depending upon how the feeding reflexes coming back. So that's true for any setup, I think, whether Indian setup or any other setup. Um, uh, any other question by the participant? Is there any neuroprognostic scoring post cooling? Some score.
Okay.
They want to post cooling, which can prognosticate for development.
Yep, I think the most indicative signs of you're talking about neurodevelopmental assessment to predict neurological outcomes. Do you think so, Dr. Suksham? Is that what the question means?
Question is there any neuroprognostic scoring post cooling? So what I can
Yes.
understand is they want to know that some scoring system which can prognosticate for future neurodevelopmental outcome.
Okay, so so Dr. Sarnet looked at clinical outcomes. There wasn't a specific score over the acute phase of encephalopathy. So you looked at things like the tone of the baby, how the baby was sucking, feeding, just a normal newborn behavior. But now what we're doing increasingly in our NICUs, and I'm sure in India as well, is that we do general movement assessments. Do you do that in India?
A general movement assessment is concerned, this is not done on a routine basis. There is one big trial going on by name of Ganesh trial in predominantly in the UP community settings only. And because everybody knows doing a GMS needs lots of patience, you need a complete setup. There should not be distraction, the bed sheet and the light and the sound and everything. Because and when to stop, how to edit these videos, and then find out is GMS okay or not. So I'm not sure any of the unit is doing it on routine basis for the GMS. And as of now, it is only on the basis of the research which is going on by name of Ganesh trial.
So in
and
our in our units,
yeah,
GMs
sure.
are standard care.
Yeah.
They are standard care now. And if anyone on the call is not familiar with GM, so general movements, we can arrange a Zoom talk for that one, but they are very sensitive and specific for cerebral palsy and future neurodevelopmental issues. So that would be one of the, I suppose in our situation, quite an easy test to do, because we do a video and we upload it and it gets assessed by trained GM assessors. And many of our staff, including fellows, nurses, neonatologists, are trained to assess GMs. And then we can target the child for early intervention depending on the quality of or the outcome of the GM test.
So another is diagnosis of definition of HIE to be made on the basis of Apgar scoring or the Sarnath scoring. So, I mean, that's a very basic thing, I think.
I think that's pretty well defined worldwide on the APGAR and the SARNET. But again, remember the SARNET scores were based on serial evaluations that continued in some babies up to a few days or a week or two of life.
With the pulmonary artery hypertension during the time of cooling.
Usually when the baby has mild HIE, pulmonary hypertension is not that severe. It often only affects the babies who are severely encephalopathic. And in our situation, we have the luxury of having nitric oxide, multiple different vasopressors such as milrinone, adrenaline, anything, so usually pulmonary hypertension is not a major issue in our setting, but if it's severe and you cannot oxygenate the baby, cooling has to stop.
So another they want to understand is, so those who do not have nitric oxide in their setup, firstly, correctly diagnose the situation. And another is early start. Another is nobody is doing bundle care for prevention of PPHN. Simultaneous bundle care by not pricking, ear muff, eye closed. You have to control your factors which are precipitating PPHN. So they have to go simultaneously. Precipitation factors has to be controlled and simultaneously management. Early starting of milrinone once the blood pressure is correct. Once the blood pressure starts dropping, the milrinone will lose the action and you will end up in juggling with the hypotension. What we use here is milrinone, sildenafil, and another is vasopressin. And recently we got also in our unit, but we had been wonderfully managing with all this. Although with PPHN continuing the cooling, the odds of death definitely increases. So another they want to understand is when to get an AEG done.
Okay, we get an AEG done or we leave the AEG machine on the child as soon as the baby is suspected of needing cooling. So it's continuous until the baby is rewarmed.
Yeah, so the residents have to understand that rewarming is a phase where you can have the seizure more commonly. Then another is there any correlation between OAE screening results and HIE severity?
What is OAE?
So it's a hearing screening. They want to understand, is there a correlation between the hearing screening, autoacoustic emissions, and any results of this screening and severity of HIE?
Oh, I'm sure there is, because the more severe the disease is, the more that the child would be affected in all of the senses, including hearing. So in Australia, we have universal hearing screening. So, it's picked up very early.
So from the participants, one more question is there. What shall be management of protocol? As ma'am told the case that developed seizures at 9 hours. Probably in your case, the seizures developed at 9 hours. So they want to understand the management protocol.
At the moment, we are increasingly losing equipoise. And if this child was absolutely normal, many of us in Australia anyway, would not cool this baby. But if this little baby was in, I guess, maybe the UK or increasing places in the US, it might have been cooled. Unfortunately, I cannot give you the right answer at the moment, and we need to do our RCT.
So I think they can manage the seizures the way seizure management protocol goes on, and the confusion should not be there that when they are talking of cooling in mild HIE, it's a stage when you decide to cool, not the, I think, maximum stage. So this is how sometimes they confuse, because during the course of HIE it can worsen. But for deciding to cool or not to cool, you have to take the situation for at less than 6 hours when you are deciding to cool, not the maximum stage, right? Yeah. So could there be a possible role of KMC along cooling?
Oh, that's very
They
difficult
want to
because
understand
KMC,
kangaroo mother care
yes,
during
right.
cooling.
Kangaroo care will, is meant to increase your body temperature and stabilize your, your thermal regulation, and that goes against the, the principles of cooling. The one of the problems with mild HIE is that if we cool the baby, we are taking the baby away from the mother, a relatively healthy baby, and that could be impairing their bonding and their connection. So that is something that we need to consider. Even if cooling is proven beneficial, we have to take into account the disconnection between the mother and the baby during cooling. I'm not sure whether it's possible to do KMC with cooling. I do not know.
No, I really doubt, and more so once the
Yes.
baby is a term baby, they don't, and they are active, they may not like to stay in kangaroo care. It's the preterm baby who are comfortable with the kangaroo care rather than a term baby who may be continuously kicking. So there are no more questions. Just I want to know, there is a one big cohort study which was done from the Sweden with 4 centers, but it's not again an RCT, where they have shown in comparison to the normal babies, there was improvement in cognitive function. Although for cognitive function on BSID scale 3, they have taken 100 as a normal, and deviation from one standard deviation from 100 was the one which they took it. They did it in 4 centers. It's not an RCT, it's a cohort study of 4 centers, where the cognitive scale showed an improvement from 99 to 103, and no other scales. This was in the babies cooled versus not cooled, the controls ones and the one with the mild HIE. So again, but if you take a cognitive scale of 100, there would be, it's like choosing very good out of the excellent. This is what I can make out. So the difference was 99 versus 103.6. So I hope the residents have got their answer. So in order to understand the situation, you need a bigger RCT. And I'm still not clear why the time study took only a sample size of 68. And we are happy that you have taken a bigger sample size study. Only thing is, still the residents later on might like to understand that uh, why to cool for 90, so the 72 hours, when mild HIE in normal scenarios progress usually up to 48 hours. And it's the moderate which continues up to 5 days or 7 days. So why do you want to cool them for 72 hours? Why not 48 hours? Maybe once you answer this and you land up in more, if you have more side effects, or your DSMB board in between finds more side effects, you would like to go for something. And then somebody has posted their characteristics and short-term outcomes of neonate with HIE treated with hypothermia. This is on the short-term outcomes. So I think we are talking of the long-term. There are lots of data on short-term outcome from bigger retrospective studies, including finding more death in small for gestation age, more deaths in PPHN, lots of data on short term. I think long-term neurodevelopmental outcome, only study which I could find was this JAMA study, which had started with a sample of, I think, 690, and ultimately with a neurodevelopment in 471. So it was a 4-center study, but it's a cohort study. It's not a RCT. So we really don't know when they're talking of mild HIE, what was this mild HIE throughout or mild HIE at the time of enrollment. So this is the only query, because in cohort, obviously, you can't rule out all the bias, but they did up to neurodevelopment of 18 to 24 months and did have some difference in cognitive functions. So that's, I think there's no, they are writing about the short-term outcome. There is a lot of work on short-term outcomes in form of retrospective studies, which they have compiled up. So any other question from the participants?
I have a couple of questions for Dr. Julie. I'm currently attending a stage in a hospital in Paris, and the standards of care and the guidelines, the French guidelines, are a little bit different from the Italian ones. So the first question concerns the use of lactates as a marker of severe encephalopathy. We don't use lactate. They're not mentioned in Italian guidelines, but they are in French guidelines. So the level of lactates is used as a marker of severe encephalopathy. What do you think about it?
I mean, the severe encephalopathy, again, from SANET is clinical. All right, they didn't do any biochemical studies. We use lactates 16 to 17 for moderate to severe. I know if you're French and Italian, you must know Daniel De Luca very well. So do you know Daniel De Luca very well?
Well, yeah.
So he and I have argued a lot.
With him.
Yeah, he and I have argued a lot about how to treat mild HIE babies. And in France, you don't have the equipoise. There's almost universal acceptance of cooling for HIE, regardless of your biochemical markers. Yeah. So I think every country is different. The basic thing is that even for severe or moderate HIE, we do not have firm evidence that cooling will benefit babies with severe HIE. So this is a very unassessed therapy, especially in babies at both ends of the spectrum, mild and severe. And every country, even every region, will have different criteria.
Well, do you think that in Italy, the use of lactates should be improved? That should be more considered or mentioned in guidelines?
I think it depends on your resources, whether your NICUs have the ability to measure lactates. I'm sure they do, but then as you know, yeah, I'm sure. But if you get 10 neonatologists in one room, they will have 20 opinions. So it's a matter of gathering your Italian neonatologists, get Paolo Manzoni or Giuseppe Bonocore in there and get them to talk and say, what do you guys want to do, man? Yeah, get them to get a consensus. Yeah.
Okay. Thank you. The second question.
Italy are you from? Which part of Italy? Which part of Italy?
Bari. It's in the south of Italy.
Lovely. Okay, very nice.
And currently I'm attending a stage at Becler Hospital in Paris, which Daniele De Luca, it's the head chef.
Say hi to him for me.
Oh, thank you. Well, of course I will do. And the second question is regards the sedation. The sedation in babies that are not intubated. In my department, we not usually intubate babies that don't need to be intubated, and we perform hypothermia in not intubated babies. In France, they intubate and sedate with the morphine and midazolam. All the babies.
Exactly. I know that from talking to Danielle. Yeah. I think in our unit, we're very comfortable with not intubating. And if the baby appears uncomfortable, then we provide some Panadol and maybe a bit of trophic feeding. And that seems to be okay for most babies. If they're extremely irritable, it may mean that the encephalopathy is worsening and they may need some support.
Okay, thank you. Thank you so much. Dr. Suksham,
Sorry, Dr. Suksham, you are muted.
Okay. So in case there are no more questions, we will take permission from the organizers for the further action or the further movement. What do they want?
We can, I think that we can end this session. Thank you so much, Dr. Suksham. Thank you, Dr. Julie. Thank you
very much. I apologize for the initial delay.
No,
no problem.
Okay, thank you for the invitation. All right, bye-bye.
Bye.
Have a nice day. Bye.